Welcome back to Bend New Menopause. I'm Vanessa Weiland, nurse practitioner and founder of Phases Clinic in Washington State. I have a really special guest with me today, Stacy Marie. She's also an adult gerontology nurse practitioner, but acute care. But that's so fun because most people in menopause care are women's health or midwifery, and we're kind of coming at it from the other side. So please let us know who you are and where you practice.
Hello, thank you for having me. You introduced me very well, thank you. I am a double board certified family and acute care nurse practitioner. I run my own clinic in Portland, Oregon, so Remedy Functional Medicine. It's a cash pay telehealth practice, and I cover Oregon, Washington, and Nevada and see patients in clinic. Yeah.
So Stacy and I both see a lot of people in perimenopause who have polycystic ovary syndrome, but that's been recently renamed.
Yeah, PMOS is the new terminology, and it just got changed a few weeks ago. PMOS is Poly-Endocrine Metabolic Ovarian Syndrome. And finally, I'm so happy that it's changing because I feel like a lot of women were just underdiagnosed or just not seen or heard with the polycystic ovarian portion of that diagnosis.
Yeah, so basically, because of the name, a lot of providers even were under the misunderstanding that you had to have cysts on your ovaries in order to get this diagnosis, but that's not true. So, what does this mean for people that actually already have that PCOS diagnosis? Does it change anything for them?
I think it changes a lot. I think it really makes it so that clinicians and patients and the general public can see that it's not just an ovarian issue. It is a full-on metabolic issue. And when we talk about metabolic health, especially through a functional medicine lens, we're looking at everything. We're looking at insulin resistance, we're looking at gut health, we're looking at the systemic effects and not just looking at the normal hormone presentations you see with PCOS.
Now that we have this better understanding that PCOS or now PMOS is this systemic metabolic issue, how do you find that if someone has that longstanding diagnosis, how do you find that it changes as they enter perimenopause?
Ooh, as they enter perimenopause, I think it changes in that there's so much more to uncover in regards to their hormone shifts. For a lot of PCOS patients, they were on oral contraceptives for so long, and then, no one really caught this underlying PCOS picture. So I'm seeing a lot of these PCOS, PMOS now diagnoses and phenotypes are basically presentations in women who are perimenopausal and they're like, oh my gosh, no one told me this. Or how it looks different in perimenopause because of the zone of chaos and rapid fluctuations of estrogen and progesterone and testosterone.
Something fascinating I've seen, and I don't know if you've seen this, is that people who had irregular periods due to PMOS earlier in life often find their periods become more regular in perimenopause. Have you seen that?
I've seen that for some people who we focus on the insulin resistance, the inflammatory piece, because we now know, especially with this new name, is that PMOS is an inflammatory condition. It really does affect so many aspects of a woman's health. And if we don't address them all, it's going to be difficult to treat or prevent more chronic diseases that we may see later in perimenopause and menopause and beyond.
And so, what are some of the diagnostic criteria for PMOS and some of the frequent treatments?
High androgens, polycystic ovaries, clinical presentations of hirsutism. And then what was your other question?
What are some of the common treatments?
It depends on patients' goals, their history, what's going on with their labs. Some women need cycle suppression. Some people really need to focus on insulin resistance and controlling obesity and metabolic health so that we can improve and or prevent the systemic issues from high androgens. There's so many different presentations of PMOS. And so, really understanding PMOS as a whole is super important as a clinician, but also as a patient because it looks different for everyone.
So for those listening, if you don't know, high androgens might show up on your lab work. So that could be high testosterone, high DHEAS, and it can also show up in physical symptoms like maybe lifelong. You've always tended toward acne or unwanted facial and body hair. And that's why a lot of these patients are maybe put on a birth control pill to control the acne, not realizing that it's also helping to treat PMOS in a roundabout way by decreasing those androgen levels. One tricky thing that I find when someone comes new to me with no diagnosis, that there's a lot of overlap in symptoms with PMOS, perimenopause, other things like anemia, thyroid disease. They can all cause irregular periods, mood issues, fatigue. So how do you help to tease that out for people?
Oh, I love this. So I love seeing the patient as a whole, but with perimenopause and PMOS, there's so many symptoms that we see, like you said, fatigue, brain fog, sleep disruption, mood changes. They are the most non-specific symptoms that we see in medicine, but I usually don't start just with hormones. I usually start with what's cheap, what's common. We're looking at iron deficiency, what's their iron, their full iron panel, and ferritin, because anemia is everywhere in this population, but that also kind of coincides and overlaps with gut health in PMOS and perimenopause specifically, looking at the thyroid, not just a TSH, metabolic markers. We mentioned insulin resistance, inflammatory markers, B12, really focus on the basics first and kind of help support the patient wherever they may be at the time.
So for you, that often involves some lab workup to see if they have low levels of these nutrients.
Lab workup, full picture. I really like spending time with my patients and really seeing a full history. What we do in functional medicine is do a basic timeline of like, when did your cycle start? How long were they? What did it look like in your 20s, in your 30s, and so on and so forth? Because once you go through that, you really see a pattern. And this is where I can see, looking back, how women can have PMOS for years and not really know it because of cycle suppression or oral contraceptives.
Yeah, I think that's one sort of myth in perimenopause and menopause care is word has gotten out that labs aren't always helpful when it comes to perimenopause. Basically, they often come back normal when we check hormones, and it doesn't rule out perimenopause, but it's used as almost a way to gaslight women. They get the labs checked as normal, and then they're like, well, it can't be that. So that is, we're always kind of coming back to this question of labs and whether they're useful, but that doesn't mean we shouldn't also be checking for things that can mimic perimenopause or, worsen those symptoms. Like you were saying, the low ferritin I see all the time. I almost never see normal ferritin. And yeah, thyroid issues as well. So I am frequently checking labs, just not like hanging my hat on hormone labs. I'm looking at those other things too. And I know you're really comprehensive in that way also.
Yeah, I mean, if, you talk about ferritin, low ferritin is, pretty common, but what are the causes? And that's where the whole like comprehensive view, a little functional medicine lens kind of comes into play, especially for patients who have PMOS, because sometimes when they do bleed, they are bleeding really heavily. And so they may be iron deficient, but PMOS patients also have severe gut issues too. And so, ferritin levels and iron deficiency can happen in these patients when we have gut issues like SIBO or not enough stomach acid, which helps convert the iron that you do eat and consume into usable form. So it's so complex, but it really affects how your hormones work, your fatigue symptoms, and there's so many different layers to it.
That reminds me of the framework. I think this is like corporate America, the 5 whys. Have you heard of this?
Mm-mm.
So someone comes to you and they say, I have fatigue. And the first why, oh, well, maybe it's just your sleep, but let's check labs. And then they might have low ferritin. And then you ask why again. Why do you have low ferritin? I think a lot of healthcare providers might not do that step. And then maybe there's 2 more whys after you figure out the cause of the low ferritin. I
Right?
think that's great. So, in your experience, do you find any overlap with PMOS patients and hypermobility, either
Yes.
hypermobile Ehlers-Danlos syndrome, mast cell activation syndrome, POTS? Tell us more
I
about that.
see this more often than not. And as a clinician, once you see things, you can't unsee them. So it's really hard not to see it in more patients who have just not been able to connect the dots. But I have patients who have PMOS and have history of endometriosis. And then as I kind of go through their medical history, we're looking at their timeline and a full picture. We're like, wait, I think you are hypermobile. Like, let's go send you for evaluation. And then they come positive. And then next thing I know, more symptoms start making sense. I have a specific patient who I love, and we found May Thurner. Basically, she has some pelvic venous compression issues that no one really saw or connected the dots with because of her PMOS history. history, endometriosis history, and infertility. And, it wasn't until she was postpartum with baby number two where we were symptomatic, had some one-sided leg varicosities, and sent her for an evaluation. We found May Thurner. So there's so much overlap with a lot of these conditions when it comes to hypermobility. And I hope that more and more clinicians and patients can see the overlap, because it's not just PMOS. It's not just endometriosis. It's not just hypermobility. And yes, you can be more susceptible for MCAS, but what else is kind of driving that picture?
Yeah, I know we're just in the realm of theorizing here because the science has not totally figured that out. But what do you think is the underlying cause that's tying them all together?
Which ones? Or like
Like
just this overlap?
PCOS and the hypermobile triad.
That's a good question. I feel like I'm not quite sure. I think the inflammatory piece is huge, but it's hard to say because there's no one root cause. I actually hate the word root cause because everything kind of affects the other. It's so multifactorial, and I don't know if there's any single one thing that links them together other than like some sort of inflammatory piece. Could it be from the fluctuations in hormones, or, this also word too, balance of certain hormones as well? So that's a difficult question to answer because it's so complex.
Yeah, well, with PMOS, we always think of the high androgens, but something that's very common is low progesterone, disproportionately low compared to your estrogen and testosterone. And that's where I would suspect there's some overlap happening, because we know the different hormones have different effects on mast cells, and the mast cells live in your connective tissue. So when they're irritable and leaking histamine and inflammation all the time, then that might be leading to endometriosis or even hypermobility. It's
like the chicken or the egg, right?
yeah,
What happened
exactly.
first, or was this
Yeah.
already there and then this just got exacerbated? Who knows? But the important part is figuring out that you can support it if you know what you're looking at as a whole.
Yeah, and looking again at the overall nutrients and hormone levels, and if there's a way to optimize those. And oftentimes, at least I'm finding that maybe I start something with one symptom in mind, and then some other symptoms start getting better that were not even really expected. So it's always so exciting to see how all these things interact with one another.
Exactly.
This is a little bit of a pet theory of mine. Sorry to cut you off.
Go
A
for it.
pet theory of mine that people who have history of high androgens and then they hit perimenopause and their androgens are decreasing, and that happens for all of us. But maybe the lab looks normal, even like pretty good for us. But I feel like people who have history of PMOS, they might be a little better when their androgens are higher because that's their set baseline. Have you seen that?
Yeah, I mean, this is why it's so important. We can do labs and we can
Mm-hmm.
see, like, we have some optimized levels and as clinicians. However, really seeing the patient as a whole, like their history, their timeline, getting to know them is so important, because if we're just looking at numbers, a high testosterone or normal testosterone that you said could cause one patient to be super symptomatic and
Mm-hmm.
another patient to be, also symptomatic, but just in a different clinical presentation. But yeah, when I manage these patients, I'm not chasing, a specific number or just topping anyone up to feel good, just recognizing that a decline from one woman's individual own baseline matter, and it's
Yeah.
to treat the person in front of you and monitor appropriately and use the tools like inside of a larger plan and not just as like a standalone fix. But basically, the level in the lab matters a lot less than the trajectory and clinical picture of the woman in front of you.
Yeah, which is unfortunate because it's so rare that we have historical labs to compare. So we're
Yeah.
just playing a guessing game. But I
Yeah.
always feel like a weirdo giving someone with PMOS testosterone, but I've had some people really respond to it. And we're not trying to recreate that high testosterone situation, but just trying to get them into like the middle of the normal range can really help with libido or fatigue.
Absolutely.
So if you all don't know, Stacy puts on training for clinicians. I've learned a lot from her thinking about that second and third why down the line. And so tell us a little bit, if someone listening is a clinician or maybe like has a good working relationship with their clinician and can point them in that direction, how can someone someone learn more about PMOS, metabolic health, that full picture from your coursework?
Yeah, you can find me at remedymeducation.com. I have several courses on just a zoomed out picture on functional medicine, how PMOS kind of, fits in there, how to look through the different whys that you said, and kind of help patients and clinicians figure out the big picture with these patients. We do have a wait list for a filling in the gaps PMOS course specifically that's going to dive in just on PMOS, the different clinical presentations and what you can kind of do about it in a functional medicine lens, whether that be in your private practice, primary care, conventional medicine, really anywhere, because just again, knowing what to look for and how these connect can really help so many patients.
So what's one thing that you wish more providers knew about PMOS?
That it's a systemic metabolic issue that needs to be supported as early and as deep as possible. Like we said, there's so many different factors in PMOS and metabolic health, and it's not just slapping on an oral contraceptive. Not that it's a bad thing to do, but just realizing that it has severe consequences if not treated and supported appropriately for a woman, especially because number one cause of death in women is cardiovascular disease. So we can prevent a lot of these things, and we can if we know what to support and what to look for.
Yeah, wonderful. So how do people actually find you? What's your website? What's your handle?
You can find me at remedymeducation.com. My Instagram handle is at Stacy Marie NP. I also have Remedy Meducation as an Instagram account as well. So you can find me on those channels and probably on some collab reels with you.
Well, thank you so much for coming on and giving us the quick and dirty on what's this change from PCOS to PMOS. What does it mean for people? And hopefully give them a better understanding and picture of where they can take that to their own healthcare provider. Thank you so much.
Thanks for having me.